Good afternoon, and thank you for joining us today in this Image Challenge Livestream event from Retina Physician. My name is Marianeli Rodriguez, and I'll be hosting you today. I'm a retina specialist with Vitreoretinal Associates, and I practice in Massachusetts. I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform. We would love to hear your comments online. You can find us on Facebook, LinkedIn, YouTube, and Twitter. You're also welcome to write on the chat and share your thoughts with us during this event. So today we'll be discussing a case that I used to see frequently during residency and fellowship, but I do not see often in private practice. So this is a 32-year-old lady that was referred to our clinic by an outside provider for possible vitreous extraction. The lady has a history of blurry vision and floaters for 10 days prior to presenting to our clinic. She denied any significant past medical history and said that she was otherwise healthy. Her visual acuity was 20/60 in the right eye and 20/30 in the left eye, and she had normal intraocular pressures. She denied any pain or photophobia. On slit lamp examination, she had congenital cataracts, but otherwise there was a normal anterior segment. There was 2+ vitreous cells and significant vitreous debris. On fundus exam, as you can see on this photo, the vitreous debris was noted to be clumping on strings of pearl or balls. The retina was attached and there were no areas of retinitis. The OCT, as you can see here, was able to capture the preretinal vitreous clumping of cells in one of the cuts. After our examination, we suspected endogenous endophthalmitis, and given the clumping of cells in the vitreous, this appeared to us as classic fungal endophthalmitis. We asked her again if she had any use of immunosuppressants, and she denied that history. We also asked her specifically about intravenous drug use, and she denied any current use, stating that she last used intravenous drugs about a year ago, and she was currently on methadone. Upon further questioning, she also endorsed weight loss, about 30 pounds in the last month, and intermittent fevers. So when suspecting endogenous endophthalmitis in a patient, it is important to think about the eye and the systemic disease as well. For the eye, an intravitreal tap should be done, and intravitreal injection, a vitreous tap should be done, and intravitreal injection should be performed. The tap should be sent for stain and cultures, and the injection of broad spectrum antibiotics. And then if a fungal endophthalmitis like this is suspected, antifungals sometimes are indicated. These patients also warrant a systemic workup with blood cultures, echo, and starting systemic broad spectrum antibiotics and antifungals if a suspicion for fungal endophthalmitis. Voriconazole initiation is recommended given that it has an excellent vitreous penetration. And the intravitreal injection of voriconazole may also be indicated. So there is no consensus on the usefulness of first planar vitrectomy, and this is only recommended if the patient is not improving despite the antimicrobial therapy after its initiation. So we expressed our concerns about endogenous endophthalmitis to the patient. We also told her that we were concerned about endocarditis, that this was a potentially life-threatening disease that could lead to strokes and other complications. We arranged for her to go to a tertiary care center as she needed admission and echo, as we mentioned, blood cultures, and then the administration of intravitreal antifungals, which we did not have in our office at that time. We don't have that in our clinic. As I said, this is the first patient like this that I've seen in 2.5 years in private practice. However, the patient did not follow up with our recommendations. We arranged for her to follow in a local hospital that carried the intravitreal voriconazole, and she did go to visit where she had the tap and inject. However, she did not make it to the emergency room as instructed. She did not show up to the ambulance ride. And then a few days later, she showed up to the emergency room with multifocal pneumonia. And after bulk cultures and IV antibiotics and antifungals, she left the hospital against medical advice and didn't have the echo as we suggested. We have attempted to contact her as the other members of the team, and we have not been able to get a hold of her. We have sent certified letters and made phone calls, telling her that this may lead to strokes. So this case left me a little bit shaken. Ophthalmology, as you know, is not immune to the epidemic of opioid addiction that is impacting our society. And we need to consider that these patients not only may suffer from endophthalmitis, possible endocarditis, but also from disease, which brought up these problems in the first place, which is addiction. Until we address the root cause of addiction, we may continue to see more and more of these unfortunate cases. Sometimes a simple complaint about floaters could be a tale of something more dangerous. Again, thank you for tuning in today. You can leave us a comment online via our multiple platforms, and we hope to see you again in about a month as we discuss another interesting case. Thank you.